Welcome to the EADV podcast. In today's episode, Dr. Sarah Walsh is joined by Professor Margarida Gonçalo, who has a particular interest in cutaneous allergies. She is a senior dermatologist and head of the Department of Dermatology at the University Hospital of Coimbra, Portugal. In this episode, Professor Gonçalo will be sharing her invaluable insights on the latest developments in contact dermatitis research. As she delves into the topic, you can expect to learn about severe drug reactions, allergy testing, and the diagnosis and management of contact dermatitis. This episode is a must-listen for anyone interested in improving their understanding of contact dermatitis and its related conditions. But before we get into it, if you haven't already, check out our program of face-to-face courses offering high-quality theoretical and practical training covering a wide variety of specialties. Applications have already opened for courses for 2024, including paediatric dermatology and infectious diseases for nurses in dermatology. Places fill out fast, so subscribe to our mailing list if you'd like to be the first to receive news of when courses go live. You can learn more at eadv.org. Before we begin, an apology to anyone watching the episode recording on the EADV Learning platform. Unfortunately, we experienced a technical issue with a video feed halfway through the episode, so the video does cut out, so apologies for that. Nevertheless, we hope you enjoy the episode.
Hello, listeners, and welcome to this edition of the EADV podcast. My name's Sarah Walsh. I'm a dermatology consultant in London, and I'm absolutely delighted today to be joined by Margarida Gonçalo, who is a consultant dermatologist, professor of dermatology in Portugal, and who has particular expertise in the area of cutaneous allergy. Now, I've seen her speak a number of times at the congresses and the symposia for the EADV, and I know that she's a really engaging speaker and has huge expertise in this area. But I'm interested to know first, Margarida, when you became first interested in cutaneous allergies, was it something that happened when you were a resident in dermatology? How did you first become engaged in this area?
So, hello. First of all, I want to thank you for the introduction. And actually, I began somehow interested in cutaneous allergy because my mother was also a dermatologist and she was working in cutaneous allergy. So since I was a student of, even at medical student, I used to translate her publications on contact dermatitis. So that's somehow. And then it was an area of expertise that no one really wanted to take over. So I began taking over from my mother. And really, I worked with her a lot on allergic contact dermatitis from plants, which was her main topic. But then, of course, I decided to go much further.
Oh, so it's really a family affair then, a family affair. Very good.
Yeah, and it began like that.
Can you recall any cases that perhaps you worked on with your mother that really made an impression on you? You said she specialized in, was it allergy to plants?
Yeah, and actually I still recall my first presentation at the European Society of Contact Dermatitis in Stockholm. I don't tell you how many years ago.
Very few, I'm sure.
Very few. I presented on allergic contact dermatitis to composite, to Dittrichia that was quite frequent among us. And someone asked me, how can you prove it's airborne? So I came home and said, I have to prove it can be airborne. So I just collected the plants, I cut the small trichoma of and patched test the patients with the trichoma. So that's why someone that just was also pushing me to go forward and try to really prove what we were saying. So that's
oh my goodness, so that's proper translational research.
Yeah.
And it's interesting, actually. I think you're right. Some of the most interesting questions arise from Q&A sessions after you give a lecture, because you're speaking to people you're presenting material that you're very familiar with, but very often it'll be someone in the audience who comes up with a very pertinent question that makes you question yourself. And I agree, that's one of the benefits of speaking at congresses. And we're here today to get an update from you on what's new in the world of cutaneous allergy. And for me, as a non-cutaneous allergist, really, in the strict sense of the word, it seems to me that the job of a contact allergist is very difficult in the sense that you are constantly following a moving target, in the sense that formulations and the constituents of products are changing all the time. Is that how it feels to you on the inside of this subspecialty?
Yeah, I think we are a bit like Sherlock Holmes, always looking for the culprits, and the culprits are always changing. Even sometimes we have the same label and they have changed the composition within the cosmetics. Sometimes it's not easy to follow, but I think it's always interesting to try to look if someone has a reaction to, let's say, a facial cream, to try to see which is the real culprit, because then we can tell her the culprit is this preservative, or is this perfume, or antioxidant, and then she can avoid all the creams or all the products that have the same constituent. Because otherwise, if we just say, well, it's an allergy to a cream, a facial cream, she will use the next one and she will have allergy again. So I think it's very important to really look for the culprit, and then we have to be always looking at the labels and sometimes doing some chemical investigation to really know what the culprit is. Otherwise, it will not be so informative for the patients.
Yeah, exactly. I think the Sherlock Holmes analogy is a good one. And I guess the other important thing is that when you are documenting cutaneous allergy, you're also looking not only at the level of the individual, but you're also looking at patterns over time. And obviously, how well do you think the regulatory agencies protect consumers from the adverse effects of cutaneous allergy? Are they responsive enough?
There is this committee, the Scientific Committee on Consumer Safety, where we have some dermatologists and some individuals from contact allergy who really give their opinions on what should be done to allergens like isothiazolinones, other allergens that are inducing many allergies. But then the problem is to translate into a directive from the EU. And next, it's the application of the directives in every country, which sometimes is not, this flow is not really very easy. I can just recall you, this week we had a meeting of the European Contact Dermatitis Group, and Ian White said that he had already reported that vitamin K should be removed from cosmetics. And this was more than 10 years ago. And some of the products that had it had been removed. And suddenly, from Spain, they are presenting more than 10 cases of severe allergic contact dermatitis of the face from vitamin K. So you see, even some directives have been produced, or some opinions have been produced, and then somehow they are forgotten, and these strong allergens come back into the market and produce problems.
So you can make all the recommendations in the world, but if there isn't any way of enforcing them, as you say, it's going to translate into problems. And of course, this constant reformulation, that's not the only challenge facing the cutaneous allergist. We're always getting completely new devices on the market, which bring their own problems. And I'm thinking specifically of these devices, these revolutionary devices, which have transformed people's lives in the world of diabetes, for measuring blood glucose on in a continuous fashion, and delivering insulin to suit the blood glucose level, because they've got problems with acrylates, haven't they? And can you tell us a little bit about this emerging problem and what is being done to combat it?
Yeah, this is a real problem because it's very, very frequent. It is a problem of acrylates, but not only acrylates. You see, these individuals have to have an adhesive stick to their skin for 2-3 weeks, sometimes more. And the first real culprit of the allergy in these situations was IBOA, isobornyl acrylate. But how did we find it? It was not information of the producers. It was due to chemical investigation, a lot of chemical investigation done, especially in Malmo and in Belgium, that they could find what the allergen is. Because not even the producers, they don't really know what it is. But now, apart from this acrylate, other acrylates have been found. And also, they find also cases of allergy to the glue, to colophony. You remember colophony was an allergen of the tapes, of the old tapes. Now they have a modified colophony that also induces a lot of reactions. And this is really terrible because these patients cannot stand neither the glucose sensors, neither the insulin pumps that have to be stick to the skin. And also, when they try to measure the real glucose levels, if they have a lot of inflammation below the sensor, the levels will not be correct, will be low. And then you imagine the pump that will work accordingly to this information will work wrong. So it's not only a problem of allergy, it's also a problem of inefficiency in a certain way of these sensors and consequently also of the pumps. The big problem is that these are medical devices, and in medical devices it's not mandatory to have the full labeling. Both the European Society of Contact Dermatitis and the ADV were working to try to change this situation. But it's not very easy because, for instance, for the glucose sensors, part of the material is made in China. And we ask, what glue did you put there? They don't know. So it's not easy to have the full composition of this material. And again, we have to be Sherlock Holmes doing all the chemical investigations.
You have to be knowledgeable about the law, international relations. It's a very diverse role as the cutaneous allergist that you have. And are there any analogies between these problems that we're seeing with the glucose monitoring and, for example, stoma bags? Because I remember, certainly when I was a resident in dermatology, it was a relatively frequent referral that people who had stomas for either, colostomies or urostomy bags would run into problems, both irritant and contact, with the adhesive materials in the bags. Is it similar to that in any way?
In a certain way, it's similar. Not always the same allergens. They have not, as far as I know, identified IBO, which was the main culprit in the sensors that actually it has been modified. But other acrylates and especially modified colophony that is responsible for these stoma protectors. But quite often, there were many cases that it was not the adhesive, but it was the liquid they applied to the skin before, to clean the skin before applying it, or the disinfected. It could really increase either the irritancy and then consequently the allergenicity of the product. But it's also a big problem because we also don't have the composition of these devices. So contact dermatitis is never boring.
And Tilly, the other thing, you sent me some very useful literature to prepare for our podcast today. And I was very interested also by the concept of new reservoirs appearing of common culprits of contact allergy. I'm thinking specifically of MI and MCI, which you've already referred to. And can you give us an update on what's been happening with the isothiazolinones?
Yeah, the isothiazolinones that have been a big problem, one of them is methyl isothiazolinone. And actually, according to EU regulations or directives, it has been removed from Live-On Cosmetics in 2017. And only a minority of the mixture of methyl and methyl chloroisothiazolinone is allowed in rinse of products. But the problem is this is for cosmetic products for personal use. If you go to professional use, like hairdressers, if you go to the hotels and you look at the labels of the shampoo you have, they still have this allergen. So we are not completely rid of it. Also, children playing with slime. Slime has this allergen. So we have published a few cases of children with hand dermatitis for playing with slime.
It's extraordinary, absolutely extraordinary. Who would have thought an innocent childhood toy could, really provoke such a problem? And as you point out, there's so many challenges, and it seems to me that the regulations are not fully protecting the consumer, which must be an extraordinary challenge for people working in cutaneous allergy.
Yes, because the regulations are not all under the same umbrella. Let's say there are for personal products, there is one commission or one organ of the EU that is responsible for professional products. There are other areas of the safety concerns that take care of this. So you have, for instance, for high MCI, you have the limit of 15 ppm in a rinse of products, and you can have up to 400 or 600 ppm in professional products. So it's so strange.
It's so inconsistent and not joined up. It's extraordinary. One other story that I was very interested in the world of cutaneous allergy in the last year or two was that of the shin pad dermatitis, and presumably a lot of cases of rashes on the shins related to shin pads are caused by irritancy or friction. But in the last 18 months, I understand that a new culprit has been identified. Can you tell us about that, Margarida?
Yeah, the first cases we also thought it was related to irritancy and friction, especially because many of these children were atopic patients. But then, even if you protected the skin, if you put the chin pads over one layer of tissue, the reaction kept going. And so we identified this allergen, acetophenonazine, that is a kind of a byproduct or a contaminant of during the production of the foam that is inside these shin pads. But it's not only shin pads. You see it also in, like, for instance, bicycle saddlers, sneakers, swimming goggles, so many other objects that are used mostly in sport activities. And so it is really a problem. It's a new allergen that is coming into the block. So, and probably there are related compounds that are found in cosmetics, and they are quite potent allergens. But this is still a story that is not fully understood. Yeah.
Yeah, and I guess as you say, the fact that there is a plausible alternative explanation like irritancy or friction probably delayed the identification of this problem. And tell me, Margarida, when you identify a new problematic allergen, how long does it typically take for that observation to translate into regulatory change?
Well, it takes quite a long time. It's not easy to convince either the industry or the cosmetic industry of the need to make these changes. I remember with the problem of MI and MCI, it took quite a long time to really convince that this was a real allergen and that we are sensitized a great percentage of the population with these allergens. And then before cosmetic industry really understood it was a problem, until we go to the safety agencies and until we have the directives, it takes more than 10 years.
So you really have to push for change, and even then it takes, well, many years, which is not very good for the consumer.
No, not very good for the consumers, but happily we have organizations in Europe that collect data from many centers. And then we are publishing them and trying to show the industry that it can be important to detect these new allergens and try to remove them. But sometimes they say, oh, these are data from patients, not from the whole population, and so they do not really believe them unless it's a very, very strong problem, and we really push a lot. But
presumably because some of these changes will have cost implications for the industry, which will be at the front of their minds. And so just changing topic a little bit, when we were in Seville last month, Margarida, you were kind enough to come up to me after my talk on severe drug reactions to share with me your experience of cutaneous allergy testing for drug allergy in the context of SJS and TEN. And I was really fascinated, and I wondered if you could tell our listeners a little bit about that.
Yeah, one of my topics for many years is skin testing or patch testing in non-immediate drug reactions, mainly in maculopapular exanthema, in DRESS, in AGEP, but also we have tested many cases of SGS-TN. We must say that it is not, in this particular case, SGS-TN, it's not the most rewarding because the percentage of positive reactions is not above 10 or 50 or 20%. But especially, it's not really so much. But sometimes you can identify the culprit. We just published the case from a young child that had many drugs and also a new anticonvulsant, and we could really prove by patch testing that it was the anticonvulsant that was the real culprit. So I think it's worth testing in non-immediate drug reactions because it is safe. Also, it is highly reproducible. We have patch tested some of these patients 10 or 15 years after, and they are still have positive patch tests to carbamazepine, to amoxicillin, to whatever the culprit is. We have more than 85% reproducibility after 15 years or 10 years medium, which I think it's very good and speaks for the real, I would say, how stubborn our T cells are and do not really change their way of mind and keep on reacting against these
That's fascinating.
drugs. Yeah.
And I think you told me as well that when you have patch tested in a case in the convalescent phase following an episode of SJS-TEN, you sometimes get lesions at the patch test site that resemble SJS-TEN. Is that correct?
Yeah, we have been performing biopsies of patch tests, and we had one case that clinically one case that we tested, it was a real TEN that we tested afterwards with carbamazepine. We tested with more concentration, so we had a severe reaction with the Nikolsky sign. And when we biopsied them, it was a full-blown epidermal necrolysis like we would have in the acute situation. And we have shown this for AGEP, where we see pustules in the patch test, and we have done it in DRESS and in maculopapular exanthema, and the clinical aspect and the histological aspect of the patch test somehow resemble the acute reaction. That is really very interesting. I think we can say that the patch test is a kind of a localized drug provocation test. So I think it's very interesting.
Like a microcosm of the reaction in the whole skin. And do you have a feeling yet, having tested a number of patients following SJS-TEN, and I appreciate it is obviously a very rare reaction, are there any families of drugs such as anticonvulsants or penicillin type antibiotics that tend to give the most useful patch test results in SJS-TEN?
The most rewarding drugs to test are anticonvulsants, and especially carbamazepine. Carbamazepine or the analogs like eslicarbazepine or oxcarbazepine, they usually have positive results. For instance, if it is allopurinol, you will never find a positive result. We've tried it in many vehicles, in many concentrations. We even tested oxypurinol, which seems to be the real culprit, and for patch testing, it is not really useful.
Oh, that's really fascinating, really fascinating. And it's been so interesting speaking to you, Margarita. And I'd just like to finish up by just asking, what aspects of your career in cutaneous allergy have you enjoyed the most?
I think that this patch testing in drug allergy is really has really been different from. It's a way of somehow going beyond contact allergy, because I think it's important to know this interaction between contact allergy and drug allergy, where you are exposed by systemic route, because some patients who get sensitized through the skin, like for instance for acrylates, they can then develop reactions when they are exposed to acrylates. For instance, when they have how do you say, in the teeth, when you apply your teeth and put some acrylate to bind it, or
fixative for dentures,
or for a bone prosthesis, you may react to it, or you are allergic to nickel and then or to gold, and you may have quicker restenosis of the when you do. In cardiology, you do this treatment, the stents, with the stents. So this is very interesting, this relation between contact allergy and systemic reactions, and also the relation between drug allergy, when you are exposed or sensitized through systemic administration, and then you develop this positive patch test. I think this has been really interesting, and I think we have to tell other people that contact allergy is not only a problem of the skin, because if you are exposed by other means, like with the drug, or for instance the case of the acrylates, namely when we restore your teeth or things like that, you may have systemic reaction. So I think there's always things to discover and things to study in patch testing.
And your detective work and your legal work. And finally, do you have any words of advice for the patch testers of the future? Presumably curiosity is very important.
I think curiosity is very important, and I think one thing that we usually, actually it's Marcus Mauro that uses it for chronic urticaria, but I think we should use it also here, and never give up. So try to go on as deep as you can in understanding which is the real culprit in every case you have to deal with. So that's, I think, my message.
So determination and curiosity, which I think would serve you very well in any area of dermatology. Margarita, it's been such a pleasure to speak to you. I've really, really enjoyed what we've talked about. I really enjoyed all the background reading, and I'm sure our listeners will have learned a huge amount from listening to you. So thank you so much for your time today.
Thank you for having me. It was a real pleasure sharing all this data with you and with our colleagues that will listen to our podcast. So bye, and thank you.
Before you go, a quick favour. If you are a regular listener to our podcast, we would love to hear from you. Your feedback will help us improve the show and develop episodes that you are interested in hearing. To participate in the short survey, simply follow the link in the show notes of this episode. Thank you for your support, it means a lot. We look forward to hearing from you. Until the next episode, take care of your skin.